come to order. As a 24-year veteran and a physician who has worked at the VA, I have seen firsthand how important coordination is to providing timely, quality care, especially for veterans with complex health needs. It's one of my top priorities in Congress to ensure veterans have access to care where they need it and when they need it. VA's care coordination programs should help veterans navigate the complex world of healthcare, both within the VA and with VA's community partners. VA's Patient-Aligned Care Team, or PACT model, provides or should provide personalized, patient-driven care and positively can impact a veteran's experience in the primary care setting. However, high-need, high-risk veterans often lack support for their complex clinical and psychosocial needs beyond that setting. This is not due to a lack of compassionate coordinators and social workers within the VAs, but rather due to poorly defined roles and jurisdictions for these advocates. Veterans who receive care across multiple locations are at the greatest risk for lapses in care, especially when their medical records are either not returned to the VA or the VA does not correctly input vital medical information. Communication between the VA and its provider partners could be greatly enhanced with coordinators who are empowered to work across clinical and arbitrary bureaucratic lines. As we will hear from the VA OIG and from our second panel of veteran advocates, veterans with complex cases who do not receive proper care coordination more often than not experience detrimental health outcomes. Some of their stories are heartbreaking. The Quality of Life Foundation, Wounded Warrior Project, and Paralyzed Veterans of America have managed to establish programs that cross multiple disciplines to effectively manage the care for some of our most complex, injured, and ill veterans. VA can and must do better. I look forward to hearing how we can better coordinate the coordinators and ensure that no veteran falls through the cracks. With that, I yield to the ranking member.
Thank you, Madam Chairwoman.
And her substitute.
Of course,
Mr.
I'm
DeLuzio.
sitting in for Ms. Brownlee today, who is still in T&I markup. I'm sure will join us when she can. As the largest integrated healthcare system in this country, the Veterans Health Administration is perhaps one of the most well-positioned to effectively coordinate patients' care. Given the patient population it serves, my fellow veterans, care coordination is critical. As compared to their non-veteran peers, veterans have a greater number of medical comorbidities and psychosocial needs that need to be considered and well coordinated when delivering health care. However, as we will hear from some of our witnesses today, there are many ways in which the Veterans Health Administration, VHA, needs to improve its coordination of veterans care to ensure veterans receive the soonest and best care possible, whether directly from the VA or from fee-for-service or community care providers. As defined by the Federal Agency for Healthcare Research and Quality, care coordination entails deliberately organizing patient care activities and sharing information among all of the participants concerned with the patient's care to achieve safer and more effective care. Despite the existence of numerous care coordination and case management programs across VHA, the committee regularly hears about instances where veterans with complex care needs have not received the help they need to navigate VHA's direct care system or fee-for-service or community care, experiencing delays or serious gaps in care. There are too many instances where veterans fall through the cracks and don't receive the care they need when and where they need it. In the most serious cases, like those we'll hear about from our Office of Inspector General witness, lapses in care coordination can lead to poor patient outcomes and patient harm. I hope today's hearing will help us examine ways VHA can address some of the root causes of care coordination breakdowns. At the outset, I see at least 3 areas to be addressed. First, care coordination programs within VHA tend to be fragmented or siloed within certain program offices or clinical service lines. They generally target specific categories of patients, diagnoses, or clinical specialties, leading veterans to be passed off from one care coordinator to another. This heightens the risk of care coordination breakdowns as veterans transition from one coordinator or one setting of care to another, accomplishing the exact opposite of the goals these programs are intended to meet. Second, information technology limitations also present barriers to care coordination. We're still years away from having integrated electronic health record at VA and DoD. Meanwhile, VA's legacy system makes it such that veterans traveling to or relocating from one VA facility to another have to be registered at their new facility before providers at that facility can access their VA electronic medical record. VA's ability to electronically access and receive medical records from from non-VA community providers is still very limited. This means that VA staff often have to request paper copies of medical records from non-VA providers, leading to delays and gaps in information from fee-for-service or community care encounters. Third and lastly, a lack of strong oversight across VA medical facilities and gaps in existing policies lead to inconsistent patient care experiences for veterans. Some care coordination programs are only available at VA medical facilities that have chosen to offer them, and even in care coordination programs that all facilities are required to offer, caseloads and patients' experiences can vary considerably. So certainly much for us to examine today and many opportunities for VHA to improve. I'd add that with the ongoing implementation of the PACT Act, thousands of veterans with complex cancers and respiratory illnesses will be entering the VA healthcare system in the coming years. It's therefore an opportune time for this committee and VHA to consider ways to strengthen care coordination frameworks and ensure VHA will be prepared to serve this cohort of veterans and their caregivers. Madam Chair, thank you again for organizing this hearing. I look forward to it, and I yield back.
Thank you, Mr. DeLuzio. I just wanted to have a point of information, and that is most of you know that votes will be coming up shortly, so we will take a recess for votes. But at this time, I'd like to introduce the witnesses today, and I'd like to thank you for joining us. Joining us from the Department of Veterans Affairs is Mr. Christopher Saslow, who is the Assistant Undersecretary for Patient Care Services and the Chief Nursing Officer. Accompanying Dr. Saslow today is Dr. Sachin Yendi, the Chief Medical Officer in the Office of Integrated Care, and if I mispronounce anybody's name, I do apologize. Ms. Jennifer Strawn, the Executive Director, Office of Nursing Services and Deputy Chief Nursing Officer, and Ms. Jill DeBoard, Executive Director of Care Management and Social Work Services. We also have Dr. Julie Kroviak, the Principal Deputy Assistant Inspector General of Healthcare Inspections in the Office of the Inspector General. Dr. Saslow, you are now recognized for 5 minutes to deliver your opening statement.
Thank you. Good morning, Chairwoman, or good afternoon, Chairwoman Miller-Meeks and ranking members and distinguished members of the subcommittee. Thank you for the opportunity today to discuss VHA's various care coordination programs within VA, community providers, and emergency services. Accompanying me today, as mentioned, is Dr. Sachin Yendi, Chief Medical Officer for the Office of Integrated Veterans Care, Dr. Jennifer Strawn, Executive Director for the Office of Nursing Service and our Deputy Chief Nursing Officer, and Ms. Jill DeBoard, Executive Director for Care Management and Social Work Services. CCICM is a practical approach rather than a program with a framework that promotes care coordination stratification across the entire care continuum. It focuses on the complex and high to moderate veterans who have complex care coordination needs. Preliminary data illustrates that our CCICM model provides positive impacts to care outcomes and increasing veteran trust scores. To illustrate this, I'd like to share one of our many care coordination and integrated care management success stories. A veteran with multiple complex comorbidities has been utilizing community emergency rooms to address all of their medical needs. The veteran has found to have 16 ER visits in a 2-month period of time. The lead coordinator assigned to this veteran was able to build a rapport and gain the veteran's trust while assessing for global needs. The urgent consults were scheduled and follow-up was obtained while connecting the veteran 3 to 5 times a week via phone. The coordinator assisted the veteran with support using therapeutic listening and motivational interviewing to empower the veteran to feel confident about their healthcare decisions. The coordinator also assisted with obtaining an emotional support animal for the veteran, which made a positive impact in their mental health and coping abilities. As a result, since being assigned a lead coordinator, the veteran has had 0 visits to any urgent care or emergency department. The veteran expressed confidence in the care team and in control of their health and wellness. The veteran is now able to proactively manage care and enlist the lead coordinator with urgent requests on an as-needed basis. While this story highlights positive outcomes, we also know that there are opportunities to enhance and improve that care coordination within our system. With the number of veterans using VA care as it grows, and the veteran patient population typically having more complex medical and social needs than any other population, that care coordination is critical. To meet these needs, VA provides a broad array of services. VHA is developing a long-term strategy to ensure all veterans across their continuum of care receive the soonest and best care possible, both within the VA and in the community. It is imperative that VHA optimizes and integrates its care coordination and services and its resources. VHA's strategy must address the current navigational and access to care challenges. Without intervention to better coordinate the care, veterans will continue to have higher rates of emergency department visits, hospital admissions, and substantial increases in healthcare costs. When fully implemented, the new coordinating care will benefit thousands of veterans and their qualified family members, increasing their access to care and improving health outcomes. Last year, VHA leadership assembled an interdisciplinary integrated project team, or IPT, bringing together the offices in patient care services, such as nursing service and care management and social work services, and our integrated veterans care team to address these challenges and serve as the team's resource and planning framework. This initiative aims to decrease navigational and fragmented care challenges through proactive identification of veterans with complex care coordination needs. The objective is to enhance and align resources to organizational needs to support stabilization of our workforce and drive innovation. Finally, under the framework for CCICM, veterans will have high-quality coordinated care that is delivered in a consistent manner across all care settings. We're serving record numbers of veterans both in the VA and in the community, with significant progress towards our timeliness goals. I was going to say Chairwoman Miller-Meeks, but you've changed. And ranking members, we appreciate your continued support and look forward to answering your questions.
Thank you, Dr. Christopher. The chair now recognizes Dr. Kroviak for 5 minutes.
Thank you. I appreciate the opportunity to discuss the OIG's oversight of VHA care coordination. The OIG's Office of Healthcare Inspections reviews the quality and safety of healthcare provided across VHA, and our reviews frequently highlight challenges associated with coordinating veteran care across multiple service lines and a wide variety of healthcare settings. My written testimony highlights some of the many issues and breakdowns that providers and patients have faced in navigating the complexities of care coordination, from enrolling in VA to receiving care at the VA, and then receiving care in the community. Gaps in any of these steps of care transition compromise patient safety and fracture confidence in the system. Unfortunately, it is during these transitions of care that the most vulnerable patients face the greatest risks. Transitioning from DoD to VA can introduce new stressors to service members and their families, and the reintegration challenges can be magnified for a veteran with traumatic brain injury, PTSD, or substance use disorder. Gaps in care coordination for those members diagnosed with high-risk mental health or substance use issues can be fatal during this period. The OIG is finalizing a national review evaluating the risks for service members with documented opioid use disorder, or OUD, as they transition their care from DoD to VHA. We found that VHA providers are not consistently placing critical information regarding the OUD diagnosis in the veteran's VA medical record. Failure to identify and document a patient's known OUD history may decrease the likelihood of a patient receiving timely VA care and support. These care coordination challenges continue for VHA patients, with many of our reports finding failures involving VHA clinical and administrative leadership and frontline staff. Our reports have substantiated unreasonable delays in responding to critically ill veterans needing emergent care, dangerous errors in discharge planning for high-risk veterans, and failures in coordinating end-of-life care for a terminally ill veteran transferring between levels of care within VA. We've also seen failed coordination between the Veterans Crisis Line, local suicide prevention teams, and emergency department staff, as well as failures with vet center staff coordinating with local VA medical centers to ensure that clients deemed high risk for suicide receive appropriate clinical support. The expansion of VHA's partnership with community providers has further challenged care coordination. Once a veteran and their VHA provider agree on a need for a community care referral, a variety of VHA clinical and administrative staff enter into a complex process to complete a simple goal, scheduling an appointment for a veteran. We reviewed VA's implementation of the Referral Coordination Initiative, which is designed to improve timeliness of scheduling community care appointments. Despite a goal of complete implementation 2 years ago, full implementation has yet to be achieved. The challenges of community care coordination continue beyond timely scheduling. Our reports have highlighted deficiencies for veterans receiving care in the community, including delays in diagnosis and treatment, lack of or miscommunication between providers, and quality of care concerns. We are in the final stages of developing a community care cyclical review, and the initial phases of data analysis support many of the issues identified in our publications. We are hopeful that these reviews will support VHA leaders' efforts to introduce efficiencies and reduce the risks associated with community care. From a quality of care standpoint, until timely clinical information sharing between the community and VHA is ensured with each care encounter, VHA has no reasonable assurance that veterans are getting the care they need. Reviews from our Office of Healthcare Inspections, as well as from our Office of Audits and Evaluations, confirm current processes put veterans at risk. We do appreciate VHA staff's exhaustive efforts to coordinate safe care across multiple venues for millions of veterans. The complexity and scale of that work will only increase as more veterans engage with the community and VA healthcare services expand in response to the PACT Act. The OIG will continue to enhance and adapt our work to support VA leaders and frontline staff with meaningful and impactful oversight, with a shared goal of increasing efficiencies in processes and assuring high-quality care delivery. This concludes my statement. I'd be happy to answer any questions you may have.
Thank you, Dr. Kroviak. I appreciate that. I now recognize myself for 5 minutes. So, Dr. Kroviak, I got to tell you, I read all your testimony. I reread the testimony from last time you were here, and I appreciate it greatly. And I found this particular set, or this testimony, was fascinating. It was terrifying. It was fascinating because it was like watching a slow-moving train wreck. And it was terrifying because I find it interesting that someone as brilliant as you are, and you are, couldn't identify the root problem that you alluded to, and it's so obvious, and it's the fact that there's no accountability. There's no accountability across any of these levels. I had my staff, which are awesome, they did the word search. There's a lot of people say accountability, right? There are 0 instances in anybody's testimony from this panel or the next of the word fired, censured, referred for discipline, nothing. You have a veteran in southwestern Nevada who committed suicide because they were essentially blown off. They had all these problems, everybody knew about it, and they weren't treated appropriately, and they committed suicide. I come from a naval background, as does my friend Morgan, as does my colleague Mr. DeLuzio. When a ship's captain is asleep in their cabin at night and the ship runs aground, the captain is held ruthlessly accountable. They're fired immediately, even though they're asleep. I didn't find any testimony of a single instance of anyone being fired, referred for discipline, or censured. And we have dead veterans. I'd like to make a suggestion for you. When these instances happen, I think every single person that is involved in that chain of custody, for lack of a better term, for these veterans should write a personal letter to the widow or the widower or the mother or the father and the children of these dead veterans and apologize to them for their lack of care. And I think every single person from the Veterans Administration in that chain of custody for a veteran that is responsible for these suicides needs to go to all of these funerals. And I'd be more than happy to submit an amendment. I'm sure everybody'd sign on it. We'll pay for that. We'll pay for your travel costs. And as soon as your folks at the Department of Veterans Affairs start going to some of these funerals like we've gone to, God, I don't know how many of my friends, you will change. And until that happens, nothing will. If you have no accountability, you do not have an organization, you have a paid mob. So can you, with a piece of paper and a pencil, could you possibly draw me a line and block chart of all of these various coordinators that currently exist and are being paid for by the American taxpayers that have been failing our veterans for decades.
Stain, you're, describing, our reports hold VHA accountable to their policies and practices, and we assign recommendations to who is ultimately responsible for correcting those actions, but we have no authority to manage or punish VHA staff in our oversight position.
Does anybody?
That would be for VA.
Okay, so check me out. I represent TOMA. It's where the whole candy doctor guy opioid thing blew up. Had a veteran commit suicide from that. We had 900 veterans being seen by a single lady that did not appropriately rate them. 600 of the 900, 2/3 have been determined that she did that incorrectly. She got fired. I was there with Dennis, the Secretary of Veterans Affairs. Fired. I want you to tell me how we can make sure that your reports, because they don't hold anybody accountable, they don't. It's a harshly worded email. I want you to tell us how we can help you to empower you to make sure that these people are actually held accountable. And by that, I mean the door hitting them in the behind as they're leaving the institution permanently. Can you help me with that?
I believe I can definitely help with that.
Thank you.
We are always thrilled to provide briefs of the work that our reports to congressional staff, and we take their interest, the local interest, and the authority they have to hold local leaders accountable for their recommendations and action plans
Thank you,
they
ma'am.
put into place.
My time has expired, and I am frustrated, but my brothers and sisters are dead. So with that, I yield back, and I recognize Mr. DeLuzio for 5 minutes.
Thank you, Mr. Van Orden. And I'll echo your very good and correct point that the consequence here is people's lives. And I think it's a good reminder of what is at stake when there are mistakes and the lack of coordination. Those are the stakes. They're serious ones. So I guess my question, I'll start for Dr. Saslow and then Dr. Krovak. I'd love to hear from you as well from the OIG perspective. I'm thinking about, first, coordination of care or the lack thereof that happens on the community care fee-for-service side. So my understanding is many providers, well, there isn't a requirement to submit records to VA in an electronic form, for instance, and some don't do it in a timely manner or at all. And I'm wondering the ways in which those lapses in coordination are impacting veterans who were serving in the VA.
So thank you for the question. One of the things I think is important to acknowledge is that we recognize that the challenges in getting the medical records back in a timely manner and being able to integrate them into the veteran's record is extremely important for that continuity of care. One of the reasons for the care coordination integrated case management project itself is because of the gaps that we have identified in both within VA and within the community care itself. Our goal is to actually be able to identify for those complex needs or moderate to complex needs that we have one individual who is that lead coordinator who will not only be able to work with the veteran, but also working with the different care teams across the continuum so that the information that we receive is not only provided in a timely manner, but also handed off to the correct individual that will then continue that care within the VA if it's necessary, or managing the care within the community.
Dr.
Yes, sir.
I'm sorry to interrupt, but just for the sake of time, I'm curious. If a provider doesn't provide any records at all, or they do it in a very untimely fashion, what is the consequence for them?
Dr. Yandy?
So I can take that question, Congressman. So previously, we used to link claims reimbursement for community care providers with receipt of medical records. That means we need to confirm that they have sent the medical records. As you rightly pointed out, the fax system is very challenging to work with. We had instances where the providers said that they had sent the records, we couldn't verify on the VA side, and we had delays with claims processing. And I believe we had several congressional inquiries asking why those claims processing were delayed. And in order to make sure that our veterans were getting timely access, we decided to waive it. But you ask a very important point, and we realize that there are challenges getting medical records back, and I totally understand that care coordination cannot be done without it. So we have 2 or 3 approaches we are pursuing. Number one, VA is one of the 5 federal agencies that participates in health information exchanges. That's a mechanism where we can get those records electronically. Those HIEs account for about 70+% of HIEs locally. And through those, we get those records, but they are not complete in most instances. Number 2, we have worked out processes with our TPA partners where if we feel that a provider is not providing records consistently, which is what you alluded to, we will work with our TPA partners to make sure that they send those records to us. And finally, as you said, really technology is a solution out here, trying to work through faxes, trying to make sure those faxes get into our medical records. It's a very laborious process, so we are really exploring some technology solutions out here, and we hope to brief you in the near future.
Thank you. Dr. Kroviak, I want to give you the remainder of my time. My question is the same. One, how bad is this problem where providers outside the VA aren't turning in records at all or in a timely fashion? And is there any real consequence, and is the lack thereof hurting care for veterans?
It is absolutely impacting care for veterans. It is not getting better from our work. I do believe technology is the solution, but I don't believe we're anywhere near making that solution a reality.
Thank you. Mr. Van Orden, yield back.
Thank you, Mr. DeLuzio. The chair now recognizes Mr. Luttrell for 5 minutes.
Thank you, Mr. Chairman. Good morning, Ms. Kroviak. I got a quick, your 1-year anniversary in this position, correct? Last year?
Now, in this position, it might be August, but I was the deputy prior to that, so it's been several years.
How many IG reports have you presented on these topics?
On community care, I can't count, but I suspect almost every report we published in the Office of Healthcare Inspections touches on aspects of care.
Is there a repetitive nature to these reports?
Yes,
Very similar to the ones that you just read for us today?
yes.
Is there anyone sitting on this panel with you today responsible for any of the issues that you listed? Directly?
Directly, I would have to assume not. I think we are talking with leaders at the table, so in terms of individuals at facility
Is there
levels.
anybody that directly reports to anybody sitting on this panel?
From any of our reports, I couldn't say, but I'm not 100% sure, but I wouldn't, they
If
would
you're
probably be
following my line of
remotely.
questioning here, and you can see how this panel is unified on these issues, we're done. And I want names. I don't want any more IG reports that get lost in the sauce and hung on the shelf where the department doesn't take it seriously. You have repeatedly done your job. Well done. It has obviously fallen through the cracks because these issues are the same issues that we keep hearing over and over again. Mr. Saslow, do you have anything to respond, any response at all to the IG report and how we can course correct this ship that is continually sinking?
Yes, I believe, as I started earlier, the entire integrated project team that we have put together really has looked at a number of those failures that does not ensure that the veterans' timely access to care or their care coordination is being addressed. And so I'll ask Dr. Strawn or Ms. DeBoer to address it a little bit further, but from an awareness standpoint, we have 2 different professions that really help to coordinate the care within VHA, our nursing partners as well as our social work partners. And so coming together and working with our integrated veterans care team, we've actually identified several different mechanisms that are going to help to minimize any of the fragmentation in care, and hopefully over the course of the rollout, to make sure that we don't have those veterans falling through the cracks. Making sure that we
How long have you been in this position?
I've been in my position as an assistant undersecretary since October. I've been with the VA for 27 years.
27 years. So you're familiar with these issues?
Yes, sir. I'm
What are we doing wrong? That's
are-
rhetorical. How do we fix the problem?
We are looking at being able to do exactly.
No more looking. We're done looking.
So I apologize for the verb, or we are in the process of addressing that through the CC and ICM framework, which will allow us to help make sure that that complex care that our veterans are sometimes losing is going to be addressed by lead coordinators, by making sure that the teams are actually effectively engaged so that it's not just you're going to go to the mental health clinic or you're going to go for your orthopedic clinic. How do we have that continuity of care to make sure that one person helps to mitigate many of those issues? And I'll ask Dr. Strawn or Mr. Board to go ahead and add to that.
So what Dr. Saslow has described is what we're calling, it's a framework. It's a care coordination and integrated case management framework. So within VA, there are multiple programs and there are care coordinators within each program. A veteran who may suffer from medical chronic conditions, may have mental health issues, may have social determinants of health issues. Those patients or veterans may have multiple case managers. And what we have found is that there is siloing and fragmentation. And so with the new CCICM framework, a veteran who needs moderate or complex care coordination will have an assigned lead coordinator. And that coordinator will assist them internal and external to VA to navigate the healthcare systems.
Ms. Strong, real quick, I'm running out of time here. How long have you been with the VA?
I've almost been with VA 30 years.
30 years, 26 years, Mr. Yendi?
About a decade.
10 years? Mr. Board?
30 years.
30 years. How many of those reports have you read from the IG? Every one of them?
Yes.
Collectively, you're over 100 and some odd years of experience in the VA, and the report has not changed in decades. I think we need to take a hard look in the mirror. And I hate to be brash, but as a veteran, I'm being brutally honest. Understand? Ms. Kroviak, will you get me those names? I want everybody that's responsible for this IG, the reporting officer, whether it's the secretary or whomever. Enough's enough. Deal? Thank you. Mr. Chairman, I yield.
Thank you, Mr. Luttrell. I'd just like to sum something up. You guys, the four of you have over 100 years of experience in the Veterans Administration, and nothing's going to change until one of you get fired. I now yield to Ms. Budzinski for 5 minutes.
Thank you, Mr. Chairman, and thank you to the witnesses. In Dr. Kroviak's testimony, she mentioned the VA OIG encouraged VHA leaders to broadly disseminate findings from the OIG's oversight publications to all facilities, to alert them of the potential risks, and to promote processes that would prevent or correct similar deficiencies at other facilities. So my question is really for any of the witnesses right now. To what extent is the VHA doing this now? And there are many lessons to be learned just from the reports of the OIG findings reported. I'm just curious, any reaction to that?
So are you asking, Representative, of how often we disseminate the information across
Yes.
the workforce? So when it has to do with something that's in my area, care management and social work, and the programs that I have oversight for, we review the OIG reports. We work with those facilities that are managing those chiefs and execs, because we take this incredibly seriously. In my 30 years, I've done care coordination across the spectrum. We can do this better, and we really believe we can. The Integrated Case Management Program, the Care Coordination and Integrated Case Management Program, which we are just starting to work on as a framework with IVC, we really do believe that we have some immature data that suggests that this will have an impact on veterans' trust, on some of the things that impact their health. So but it is new. You know, we began this process in December. We are going to be deploying this to 12 sites across the country no later than September. They've been selected, and we really believe that we can start to see the needle move. We take our own responsibility incredibly seriously.
And could I just follow up with Dr. Kroviak? Would you want to add anything in addition?
So it is challenging, and I appreciate the frustration that hundreds of reports are published. But the reality is when we go into sites, though we find dedicated skilled staff, we do have repeat findings on site specific to individual facilities, and certainly we can go on site to one facility and find similar findings at others. So I don't have as much confidence that these reports are being disseminated or studied as a true risk assessment tool that we would hope for.
Mm-hmm. Okay. Okay, I have a question for Dr. Saslow. The OIG also shared their assessment of VA Video Connect, VVC. VVC is a crucial tool for older veterans, those with mobility issues, and vets living in rural areas like the district I represent. The OIG found that VHA was not able to support the increased demand for VVC despite having created emergency preparation plans for disaster scenarios plans created prior to the pandemic. Dr. Saslow, I think we can all agree no one anticipated, obviously, a pandemic like the one that we just experienced, and VHA was doing their best to care for our veterans. Now that the pandemic is over, what improvements has VHA made to the VVC program, and is there a plan in place for future emergencies?
Thank you for the question. One of the things that I think is really relevant is the fact that VVC, as it rolled out, was something that we did as a reflex to the pandemic, whereby it was already established earlier on, just not to the degree. What we learned as a result of the project itself, or the program, is that we have a lot of opportunity to improve and also increase the way that we expand it. We partner with our Office of Rural Health, which is looking at different modalities in which we can expand that connection piece to our most vulnerable patients. And so within VHA itself, we have multiple program offices that are working in tandem with the Office of Connected Care in order to make sure that VVC is actually more robust than it ever has been before. We're also using our opportunities with integrated veterans care so that those veterans that need the care consistently and are at risk for not being able to do it in person have a consistent process that we use in order to engage them. Dr. Yandy, I don't know if you wanted to add anything else to that.
Yeah, and I think just a follow-up question, in rural communities in particular, when you're looking at coordination and unique challenges that they face, could you speak a little bit more to like what those are and how you're working through those challenges?
So one of the things that is probably the most challenging at times is bandwidth, in making sure that our veterans who may have the opportunity to have a connected device, which we have the opportunity to provide for, doesn't always necessarily have the necessary bandwidth in their area in order to make those connection pieces the most stable or consistent. And so our Office of Connected Care is working with a lot of the different community providers, Verizon, T-Mobile, et cetera, to try to find ways that we can enhance and expand that bandwidth itself. That's definitely one of the biggest challenges I think we've seen in our successful expansion of the VVC program.
Okay, thank you. And I think I'm out of time. I'll yield back, Chairwoman.
Thank you, Ms. Budinsky. The chair now recognizes Representative Matawagan.
Thank you, Chairwoman Miller-Meeks and Ranking Member Budzinski for holding this hearing today. And thank you to the witnesses as well for your testimony. Dr. Saslow, in your testimony, you discussed VA's efforts to simplify veteran referrals to community care via the Referral Coordination Initiative, or RCI. This initiative has been in the works since before the pandemic. Yet VA OIG states in their testimony that no VA facility has fully implemented RCI. They also state that there are no clear staffing models or mechanisms in place to evaluate whether staff are meeting goals. Community care is VA care. What is VA doing to ensure that veterans do have the access and care coordination they deserve? I think this is kind of following a little bit along Eli Crane's questioning.
So thank you for the question. I'm going to defer to Dr. Yandy because I think the Integrated Veterans Care Program really can touch on some of the opportunities that we're addressing.
Thank you for that question, Congresswoman. A couple of questions there. I'll try to answer all of them. So number one, you're right. RCI was an initiative started to help veterans understand their options for direct care and community care. And at sites where it has been implemented, we have seen reduction in access times. But you're absolutely right. We need to do a better job in terms of implementing RCI across the enterprise and making sure that we give some guidance in terms of staffing. Number two, you asked a question about how we are trying to improve care coordination for community care. So we started a community care program, PC3 and Choice were present prior to it, but we really started our community care program in 2018 through community care networks. Since then, we have seen a huge increase in utilization of community care. When we implemented policies, we have very clear guidance to the field that there would be care coordinators in our community care offices. These care coordinators look at the request for community care. They do a risk stratification, which is standard care coordination process. Consider a veteran who needs to go and see an orthopedic surgeon. Let's say the veteran does not have transportation. It is the role of the community care RN, care coordinator, to help the veteran make sure that there's transportation in place so that they can get to their appointment. So that is an expectation from that office. But as OIG and several of you have pointed out, our care coordinators are currently siloed. We have care coordinators on the direct care side, as well as we have care coordinators on the community care side. And so what we are trying to do with the CCICM framework, and as part of this IPT we started last fall, is really trying to bring all the care coordinators together, identify who would be the lead, and help the veteran. Now, in a given scenario where the veteran is going out to the community, let's say they're trying to get orthopedic care, the best person to coordinate that care could be the community care coordinator, but in some cases it might be the PAC clinic care coordinator. So we are trying to work out those processes as to who could serve as the care coordinator for those complex veterans and can help with that care coordination process.
Thank you. Dr. Saslow, in your testimony, you note the importance of a strong care coordination between VA and community providers. However, we often hear from veterans that are either wrongfully denied community care or their community care referral is delayed. In your opinion, what can be done to streamline community care referrals? How do care coordinators fit into this process anyway?
Thank you for the question. I think it's important to recognize that the framework that we're talking about is not building a whole new set of case management or care coordination. What it is doing is trying to identify how best to serve that veteran's needs. And if those needs happen to be for community care referral, identifying, as Dr. Yendi said, the individual who has the most effective ability to ensure the veteran's care would be the person that is identified as that lead coordinator. In turn, that lead coordinator then works with either the community partners directly or with the hospitals if the patient is going into the hospital for the orthopedic surgery, coming back what those needs might be for the patient in order to be able to go home safely and effectively in order to get the kind of care that they need. So that lead coordinator is really going to be the piece that we're hoping will help to reduce the silos that we have had in place related to the different areas where care coordination and case management already occur. Having a lead coordinator will help us to be sure that we've got one person who is identified and within the patient's record who is easily recognized for helping to coordinate that care.
Thank you, Chairwoman Miller-Meeks. I yield back.
Thank you, Representative Radewagen. It sounds as if we have too many care coordinators and not enough care coordination. So I'm just going to ask that question of both Dr. Yendi and Mr. Saslow. Does the VA have too many siloed care coordinators? Maybe that's the appropriate question.
So I think the fair answer to that is we don't have enough individuals working for care coordination or case management. What we have is a lack of someone being identified to be able to coordinate the multiple layers that oftentimes go with a veteran's complex care. So we have many of our veterans, as you're aware, have multitudes or have numerous care issues, whether it be behavioral health, medical, psychosocial, and so having one person identified as that lead will help to break down those silos, working with those care coordinators or those case managers within the other arena so that the care is now identified as a responsible process and that we can have communication that is going to be a lot more effective. Dr. Yendi? Dr.
Yendi?
Yeah, and if I may give an example, you rightly pointed out we have silos. But let's take a veteran. I think one of the panelists are going to describe a veteran who had PTSD, who had issues with cancer care, which was going out into the community, and had other issues that they had to address. Care coordination is a fairly sort of sophisticated function. People need to have an understanding in terms of care coordination in that particular area. So imagine that veteran who needs care coordination for their mental health and needs care coordination when they go out in the community. Both these skills won't be available in that same one individual. So we need to have care coordinators in these individual areas within VHA. But what you have rightly pointed out is, assuming that these care coordinators are providing the support to the veteran, how does all this get coordinated? And that's exactly what we're trying to do with CCICM. And also please understand that care coordination is not a static function. A veteran on a given day might need help with oncology care, and the oncology navigator or care coordinator may have to step in and guide the veteran. But 3 months from now, the mental health issues may become more predominant, at which point the mental health coordinator who has the necessary expertise in that area needs to step in. So we really are trying to design a system that can accommodate the veterans' dynamic needs, rather than saying there is one person who is always going to coordinate all of your care throughout your lifetime. That's really what we are trying to achieve here.
You know, our witnesses on the second panel recommend that the VA establish essentially a coordinator for the coordination either at the facility or the VISN level. And maybe what's required is that there is one coordinator assigned to the veteran instead of a facility coordinator who then coordinates only a specific medical entity or a specific problem. One of today's witnesses referenced the Federal Recovery Care, FRC, coordinator program and its utility during the surge of complex injuries post 9/11. Why did the VA move away from this program, and how is your latest care coordination, IPT, using any lessons learned from this joint DoD-VA program? Mr. Saslow?
So I'm going to ask Mr. Board to go ahead and take that.
Yes, ma'am. So what I would say, Representative, is that as far as the FRCs, they were really very critical right in the wake of the OEF, OIF, OND conflict. So we were really intensively elevating, everything that was happening on for care coordination very high and just hitting it hot. I would say today, what we are doing with CCICM, which I'm talking with our Quality of Life Foundation and Wounded Warrior Project colleagues, is that we have an opportunity to take CCICM, this lead coordinator, and elevate that person's authority, their knowledge base of all systems, so that that person really can do a similar job as what they did in the FRCs. So I think what we're hoping to do, and again, it's new, we recognize that we're in the infancy, but as we continue to roll this out, that the training allows these people an elevated status, that they know multiple systems, they speak multiple different languages, DOD, community care, VA, and are able to help the veterans navigate those systems and feel the authority to elevate things when things are not getting through that need to happen.
Program that was working, it's not the status that is required. It is that the coordination is given. And with that, I'm going to thank our witnesses on the behalf of the subcommittee for their testimony, for presenting to us today. You're now excused. The second panel, we will resume with the second panel after we go vote. So we'll resume after votes. Welcome, everyone, and thank you for your participation today. On our second panel, we have Ms. Andrea Sawyer, Advocacy Director with the Quality of Life Foundation, Mr. Matt Brady, Director of Complex Case Coordination Program with the Wounded Warrior Project, and Mr. Roscoe Butler, Senior Health Policy Advisor with Paralyzed Veterans of America. Ms. Sawyer, you are now recognized for 5 minutes to deliver your opening statement.
It's Andrea Sawyer, and I am the Advocacy Director for the Quality of Life Foundation, a national nonprofit organization founded to address the unmet needs of caregivers and the nation's most seriously wounded, ill, and injured veterans. We have evolved directly to work with veterans and caregivers as they attempt to apply for and navigate the Program of Comprehensive Assistance for Family Caregivers and other clinical support programs within the Department of Veterans Affairs. Serving all generations and focusing the majority of our time on those with significant wounds, illnesses, or injuries, we often assist those with complex clinical needs. Additionally, I am the wife of a seriously injured, medically retired, and medically complex combat injured veteran, and I've been managing his care since his return in 2007. As one of the few organizations working exclusively with the Veterans Health Administration, Quality of Life Foundation has had a front row seat to witness and help others utilize many of the programs and services available within the VA. While we do not provide clinical recommendations of any kind, our role is to ensure that veterans and caregivers are prepared for the PCAFC process, assist in the drafting of clinical appeals to ensure the VA is following its own regulations and directives, and we assist veterans and caregivers in navigating other programs and supports available to them within and outside of the VHA, specifically the Veterans Health Administration. Through our work directly with veterans and their caregivers, done so by reviewing the medical record, we help advocate for the population we serve within all VHA programs. Many of the cases that come to us have a lack of whole health coordination and management. Many have some basic care coordination, better known as a primary care treatment plan. Some have care managers who resolve simple issues or referrals through low-level intervention. However, many of our veterans have multiple complex care needs and no one to create a case coordination and case management plan. VA is severely lacking in case management services. Case management is a time-intensive level of care management that looks at a veteran holistically to document and manage all the veteran's conditions and any social environmental issues that develop as a result of the care needs of the veteran. As such, Quality of Life Foundation makes the following recommendations. Number one, create a cadre of specially trained case managers similar to the Federal Recovery Care Coordination Program as envisioned by the Dole-Shalala Commission, who can manage the most complex cases by developing comprehensive treatment plans for each need that a veteran has. These case managers should have a VISN-level lead. Second, ease the process of obtaining a case manager. Per our written testimony, it is hard to ask for one what one does not know about. Third, review the current community care network and outside provider records integration process. Fourth, review the actual caseloads of different care and case management and social work teams across the VA and ensure that different roles are being filled as individual jobs and not as collateral duties. Fifth, establish a pathway to advocacy for outside organizations to officially assist veterans and caregivers within VHA so that all veteran service organizations and nonprofit organizations are able to effectively advocate within VHA. In conclusion, Quality of Life Foundation believes VA needs to simply realign their resources and bring back older, more robust models of case management for those most severely impacted veterans. These program models have existed in the past, but then case management was siloed and veterans suffered. The original veteran case management plans, not current vet-centric plans, should allow the veterans' treatment goals to be the focus of the plan. Allowing VSOs and nonprofit organizations to advocate for care that exists within the system would also help veterans and facilities focus on the needs of veterans. Veterans would get more timely, appropriate care with the help of a holistic, full-time case manager with authority to cut through VA red tape. Veterans with lesser care needs would then have access to lower-level care managers available to them. Overall, VA would save money if veterans are able to get timely, appropriate care that is managed across the spectrum of the medical community, and veterans would have better health outcomes and quality of life. Thank you for your time, and I look forward to answering any questions you may have, especially about the Federal Recovery Care Coordination Program. Thank you.
Thank you, Ms. Sawyer. Mr. Brady, you are now recognized for 5 minutes to deliver your opening statement.
Thank you, Chairwoman Miller Meeks, Ranking Member, and distinguished members of the Health Subcommittee for this opportunity to speak about care coordination at the VA. As you know, effective care coordination not only produces better outcomes, but gives the veteran confidence in their system of health. To frame the issue of today's hearing from Wounded Warrior Project's perspective, our goal is to help warriors receive the appropriate care in a timely manner in the setting they want. We provide care coordination as part of 3 programs. The first is our Complex Case Coordination Program, which helps veterans with complex cases that are multifaceted and need urgent action to address mental and physical health care needs, utilizing high-quality VA or community-based services. The second is our Independence Program, which helps veterans with moderate to severe brain injury, paralysis, and neurological conditions live more independently with a better quality of life. The final is Warrior Care Network, which aims to reduce gaps and inefficiencies in mental health care delivery through innovation and collaboration. Based on these programs, we have a number of recommendations for Congress to consider, all of which are outlined in our written statement. Today, I want to point out 3 specific bills and discuss some targeted ideas that may inspire future bills for the subcommittee. The first bill is H.R. 3520, the Veteran Care Improvement Act, specifically Section 2, which would codify an access to care standard for the VA's mental health RRTPs. If somebody today decides to turn their life around, ask for help with substance or mental health care, why would we allow them to wait 30 days to get that care? If this was your family member, you would not find this acceptable. We can do better. I know we can do better. Also, additionally, we can do a better job communicating of records between the VA and the community residential care facilities, address follow-on care and medication needs. The second bill that I'll highlight is H.R. 452, Elizabeth Dole Home Care Act. A key provision would instruct the VA to provide informal geriatric and extended care program assessment tools to give options to the eligible veteran and caregiver, letting them decide which programs are appropriate for them. And if a caregiver is denied or discharged from the caregiver program, the VA needs to help find and enroll them in other VA-provided home-based care and support. Lastly, I'll note our support for S. 1792, the CARE Act. Section 3 has the potential to transform how organizations like ours advocate for veterans and their family members in navigating VHA programs and services. Our organization has been delivering this kind of help for thousands of veterans, and we know the life-changing impact that an advocate can have when people need help. To that end, I'd like to close by speaking to our interest in seeing the VA create a system that helps centralize care coordination and patient advocacy, particularly for those with complex needs. There are several pilot programs across the VHA that are currently exploring how we can improve integrated case management. But the fact is, Veterans need consistent, coordinated care now. We understand the VA, like many organizations, continue to experience staff shortages in critical areas. We appreciate everyone who chooses to work to make veterans' lives better. Our recommendation can be instituted rather quickly. Designate a lead social worker, your best social worker. You know who they are. At each VA medical center, have them serve as the lead for advocates to address critical coordination issues. Serve as the organization's subject matter expert. And most importantly, having the authority to cross service lines and facilitate immediate assistance. Care coordination is only part of the solution. We must also empower veterans and advocates with the knowledge about the access to care standards and their options in care. Help them actively participate in their care by providing them with information, resources, and education, allowing the veteran to make informed decisions, effectively communicate their needs, and take ownership of their health. Thank you again for the opportunity to testify. I look forward to your questions.
Thank you, Mr. Brady. Mr. Butler, you are now recognized for 5 minutes to deliver your opening statement.
Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the Subcommittee, Paralyzed Veterans of America, would like to thank you for the opportunity to submit our views on VA's efforts to coordinate veterans' care. Veterans with complex healthcare conditions like spinal cord injuries or disorders receive care from various healthcare professionals to include primary care physicians, a wide range of specialists, visiting nurses, and caregivers, many of whom are family members. This care is provided through a number of service points. It may be provided at one of VA's 25 SCID centers, through VA's 6 long-term care centers, or at other VA facilities. Care may also be provided through community care providers in state veterans or community nursing homes or in veterans' residence. This often poses a difficult challenge to the many dedicated professionals who are working tirelessly to ensure that the delivery of high-quality acute and long-term care is administered by the right providers in order to achieve optimum care outcomes for veterans. However, when coordinating care outside of the department, VA's ability to coordinate care drops dramatically because most civilian facilities and agencies are not knowledgeable or equipped or properly staffed to handle SCID patients' acute and long-term care needs. PVA is concerned about VA's current lack of long-term care beds, which is severely impairing its ability to coordinate care for veterans with SCIDs. More than half of the veterans on VA's SCI registry are over the age of 65, and the number of veterans needing this level of care is increasing rapidly. Nationwide, there are very few long-term care facilities capable of approximately serving veterans with SCID, and only one of VA's 6 specialized long-term care facilities lies west of the Mississippi River. Today, VA care coordinators spend a tremendous amount of their time attempting to locate providers, facilities, or agencies in the private sector to meet SCID veterans' long-term care needs. To be clear, these were scarce prior to COVID, and VA SCID care coordinators tell us they are getting scarcer. Nursing home and home health agencies often pursue contacts with VA, but don't maintain them long enough once they find they lack the necessary training to perform the critical tasks like bowel and bladder care that some veterans with SCID need. Facilities lacking proper staffing, are often unwilling to procure additional personnel for SCID veterans whose greater care needs consume a larger than anticipated share of their existing workforce time. Even if they are willing to hire additional personnel, nationwide provider and nursing shortages will often preclude them from finding the personnel that they need. These starts and stops are frustrating to veterans and those who coordinate their care. The 65% statutory cap on what VA can pay for home care can almost impact care coordination because it limits care options, which may contribute to unfortunate results. In light of the limited access to VA facility long-term care and the desire of many veterans with SCID to receive non-institutional long-term care, VA must expand access to home and community-based services to meet the growing demand for long-term care services and supports. Facility-based long-term care services are expensive, with institutional care exceeding costs of HCBS. Studies have shown that expanding HCBS entails a short-term increase in spending, followed by a slower rate of institutional spending and overall long-term care cost containment. Reduction in costs can be achieved by transitioning and diverting veterans from nursing home care to HCBS if they prefer it, and the care provided meets their needs. Passage of H.R. 542, the Elizabeth Dole Home and Community-Based Services for Veterans and Caregiver Act, would address many of these barriers to care, and I cannot stress enough how important it is for Congress to pass this important legislation sooner rather than later. PVA appreciates the subcommittee interest in this critical area, and I would be happy to answer any questions you may have.
Thank you, Mr. Butler. I'll defer my questions until the end so that other members can address the panel, and I now recognize Ranking Member Brownlee for any questions she may have.
Thank you, Madam Chair. And I'm sorry that I was not able to be here for the panel one discussion, but I did read the testimony, and this question really is for any of you. But we heard today from the VA and their testimony about their rolling out a new care coordination framework and management system to have one point of contact within a patient's primary care team to help ensure veterans' needs are met. So based on what you heard today, and this is, are you confused as I am? And I'm curious to know if you've heard of this program before today, because for me, it was the first time I had ever, I read the testimony, but it was the first time I became aware that this was underway. And do any of you think that this is going to solve the problem?
I'm going to put on two hats here. I am the Advocacy Director at Quality of Life Foundation, but I am also a caregiver for a warrior who returned in 2007 and was severely injured with multiple conditions that we had to manage. So I would tell you that CC and ICM with lead coordinator has existed probably since the dawn of time, and what we used to call it was you needed a case manager for your case managers. So for those of us who had warriors coming back at the beginning of the war, 2006, 2007, like I had a bazillion case managers on the DOD side, transition over to VA. I have I just add more to the layers. Everybody's talking past each other. Originally, the person managing those was me. Until we met up with the person who at that time was head of the newly stood up Federal Recovery Care Coordination Program, and I managed to get a case manager for my case managers. And that person had federal level authority across DOD, VA, Medicare, could work in some Social Security programs. So for my warrior and for many others that had that same level of case management need, that program was there. If we were only within the VA, the person that would have handled care would have been OIF, OEF, which is now the M2VA office, or potentially a polytrauma case manager. Those models have changed through the years. Basically, the FRC program rolled down into kind of a consultant basis, but then a consultant on just the VA. A VA facility consults the FRC program. You no longer have interaction with the warrior. You can refer, as organizations, we can refer people to the program. They look through the record, and then they can contact the facility to engage the facility, or the facility, if they have a difficult case, can engage the program. But basically, if you don't know they exist, and there are, I believe, only 10, I think, within the VA now, where there used to be, I think, a robust program of 75 or more across the country, and that number may be a little elevated. But they just don't exist like they did anymore, and there's certainly not that level of case management at any facility. Do I know that CC and ICM is rolling out again? Yes. Do I think it's something we had before? Yes. Was it adequate? No. That's why Dole Shalala stood up the FRC program. And when I was listening to that and to the VA testify, and they said that, you know, we came in hot and heavy and we kind of triaged folks and took care of them. What I'd like to say to the VA as the caregiver of one of those warriors is, just because you changed your model of case management didn't mean that my veteran didn't have the same needs. And so basically they took away our, not in our case, because I felt like the devil to keep him, to keep our FRC, but in a lot of cases, they just took away these case managers and left caregivers to navigate the system on our own. And as a caregiver, while I'm good at that, that's not my intended role. It's to provide that daily support and supervision. It's not to medically case manage them. I had to go to VACO and fight very hard to get a coordinated treatment care plan that still exists today for my warrior. And in a lot of cases for advocacy, I'm so sorry, in advocacy, that is what I advocate some of our most seriously injured cases or impacted cases do for their warriors also. And we talk about how we get it done, you know, how to get it done.
Well, thank you for that, and your warrior was very lucky to have you, and I yield back.
Thank you, Ranking Member Brownlee. I now recognize Representative Van Orden for any questions he may have.
Thank you, Madam Chairwoman. Ms. Sawyer, I read your testimony, is gut-wrenching. I want to know that veteran in Arkansas.
Yes, sir.
Who's their congressperson?
I can't tell you who their congressperson is on the House
You
side.
do me a
I'm
favor?
so sorry. I will find that. We work with Senator Bozeman a
Okay,
lot.
please do, and I'd like to speak to him or her personally about
Yes.
this, and I want to make sure that this issue is resolved. And in that spirit, I'd like the name of every single person that veteran has come in contact with, because I will be holding them directly accountable.
Well, I appreciate that. And
Okay.
I will say your staff has been involved in that case with me since 2016. And the staff on this committee has been wonderful to work with.
They are awesome.
Yes, they are.
Okay. In the break, I didn't just vote, I had my crack graphics team develop something to help the Veterans Administration figure some stuff out. This is that's a wheel. It's been invented a long time ago. I'll give this to you if you'd like. You can take it home, put it on your desk. You're reinventing the wheel. And the ranking member, boom, spot on. You've got institutional knowledge of the Veterans Affairs Committee. And if she doesn't know that it's going on, and our chairwoman, nobody does. So, Sergeant Major, Command Sergeant Major, I apologize. You put in here that There are a lot of veterans in this population who remain confused by the number and types of VA services, employees, roles, their delivery and eligibility criteria. Okay? You wrote that. I got, I don't know, 300-400 Facebook messages and emails and phone calls. I know that Congresswoman Kiggins did also, because the Veterans Administration was capable of pumping out some ludicrously political garbage on their website, terrifying our veterans. Everybody knew about that. It was a lie. The Veterans Administration lied for political purposes to our veterans, terrified them, and that went out like on a coconut wire, dude. But our veterans don't know the services that are available to them, and that is shameful. And we are waiting for a public apology from the Department of Veterans Affairs and waiting for them to use their public affairs officers to get out the word, the truth, to tell people the services that are available, because they are available. The Veterans Administration, they work so hard. I'm incredibly proud of our VA. I get all of my health care through the VA. I'm a 100% service-connected disabled veteran. And I go to TOMA, and I'm proud of them. I was just there last week. I told them I'm proud of them. So, Ms. Sawyer, I'm gonna have to disagree with part of your testimony here, and this is why. You're good. The establishment of a cadre of specially trained case managers, no. The Veterans Affairs Committee has not done what the Command Sergeant Major would call troop to task. They got plenty of people sitting around, and they are working, and they are qualified, and they're dedicated. But they need to do troop to task, Command Sergeant Major. They need to be able to draw a line and block chart where I can put my finger on it and say, this person is directly responsible for this veteran's care. And if that veteran winds up committing suicide, that person, not a system of a series of things, the system isn't responsible. An individual is responsible. That's what you guys need to do. And I'll be frank with you. The only thing missing from the word salad testimony that you guys gave today was a bucket of ranch dressing, and it's unacceptable. Use 50,000 words to say nothing, and we're not taking this anymore. I will not allow our veterans to be disabused or ignored or commit suicide because a bunch of bureaucrats can't get their act together. So, Ms. Sawyer, you're doing God's work. Advanced Sergeant Major, you are too. Mr. Butler, you have my undying support. So thank you very much for what you're doing, and with that, I yield back.
Thank you, Representative Van Orden. I now recognize Representative Kiggins for any questions she may have for 5 minutes.
Thank you very much, Madam Chair. I don't necessarily have any questions, just a couple comments to piggyback off of Mr. Van Orden's remarks. And I was geriatric primary care nurse practitioner, so for me, and having to coordinate care with the Veteran Administration on a civilian side, I know we're doing some good work with community care and really trying to incorporate them, but half the battle, maybe it's in charting. I know we're working through some of the charting systems with the VA. I hope that's a step in the right direction, but having patients that receive just VA healthcare, I would almost throw up my hands. And getting the charts, the diagnosis, the med list from the VA was next to impossible. We would just kind of write it off if you got care at the VA, and the caregiver it would be their responsibility to try to communicate with the civilian provider what happened to the VA and vice versa. So we can do so much better. I know Mr. Van Orden hit on the fact that, when we had that little political stunt about Republicans taking away veteran benefits, which again, fabricated lie, but I too received multiple hundreds, like he said, of comments and emails saying, why are you taking away my health care? So the VA has the capability to get that word out to veterans. So use it in a constructive, good manner, not for political games, which we hate, and I know why I ran for office, to not do those things and to advocate for our veterans, for our military men and women. So we need to prioritize, and I know that so many of us on this committee today are willing to work to do that, especially those of us who are veterans, who are healthcare providers. I think we understand that language. So we're going to work together to make sure the word gets to our veterans. I'm having to hold an event in my district to inform veterans what resources are out there. I'm having to put that event together. The VA should be doing these types of things and educating. I know as a primary care provider, it was so hard for me to understand what resources were available to veterans, to caregivers and their families. And it shouldn't be that hard, but I don't know, the VA should be educating providers, primary care providers especially, but we can do so much better. So we're going to work together and get that job done for you all, but thank you for your advocacy and work as well. And I yield back.
We will do a second round of questioning, and I would like to recognize our ranking member for 5 minutes.
Thank you, Mr. Chair. I appreciate it very much. So, Ms. Sawyer, going back to your conversation on my first question.
Sure.
So you're recommending, a case management, social work lead operation. It sounds more like going back to the good old days where it was working better, correct?
Yes, ma'am.
More or less. So you're suggesting that the point that this should happen at the VISN level. And let me just say, I think for some of us who have served on this committee for a while, and I'm one of those, we get really nervous when the VISN has control of something that we believe is very important and critical to the health outcomes for our veterans. Because the VISN has medical centers, VISNs, they have their autonomy and kind of do things the way they want to do things.
Right.
And I get very frustrated because we've got a gazillion people with coordinator titles out there, but some of them have, a tenth of an FTE or whatever. So tell me why that's where you want to start.
So I actually want to start in the facility levels, okay? And that's a little bit of I think in the oral statements it gets a little lost. I want to start at the local facility levels. And it's not that, I think there are tons of care coordinators out there and care managers, care managers are really defined by single disease or injury or condition. I want at the local level some of those folks, instead of being siloed in their care management roles, to be trained for full holistic case management of the veteran. But right now, at the VISN level, there is no person for a case manager to go to. So I'd like that there's like the VACO level and the should exist at the facility level but doesn't, and there's no layer in between. There's no authority of that case manager to do anything. Yeah. And that would be the reason to add a level at an intermediate level at the VISN to give that case manager some authority. But also going back to another part of that plan, when we talked about those federal individual recovery plans, that is what an FRC put together. It was a veteran-led plan where the veteran said what he wanted his care management goals to be. Currently, VA leads a vet-centric model where the veteran is at the center and the VA tells the veteran what they're going to give them. We want it to be the other way around. And the third thing we'd like to do is for VA to have some more centralized authority as far as case management is concerned. Right now, what we see is standardized authority throughout the VA, which allows every single medical facility and every single VISN, as you said, to kind of look at what the standard is and then apply it as they see fit. And so there's no, as we said again and again, accountability, because everybody can say, oh, well, it was standardized. It's not centralized authority. It's just standardized. It's a suggestion that I just have to fulfill. We want it to be a more centralized authority so that there is someone to hold accountable. Here is your model. Here is what you are required to do. And should you fail to do that, and should there be a medical consequence for this, patient. There is someone to hold accountable when, God forbid, somebody winds up in the hospital because their care wasn't coordinated and then they have an infection that's bad enough that they lose their leg, which is what's looking like it's going to happen in our case in Ohio.
Thank you for that. And Mr. Brady and Mr. Butler both, thank you for mentioning the Elizabeth Dole bill.
Yes.
Appreciate that very, very much. I wanted to ask you, Mr. Brady, you talked about I guess it's a nomenclature problem that you talked about in terms of younger veterans and the way we recognize some of the long-term care services, geriatrics and so forth, that can be pretty confusing and may stigmatize, et cetera. Do you have some suggestions around destigmatizing and improving outreach efforts for younger veterans who may need the long-term care services?
Ranking Member, thank you. Yes, absolutely. The first easiest thing to do is to not have every picture of geriatric care being somebody over the age of 70. That's the first easiest thing. We had a meeting with Health and Human Services to talk about where there was potentially some overlap in services that they could be giving. But the conversation centered around everybody in the room looking at every picture, every website, and there's no way that veterans see themselves as that. I still feel I'm 34. My wife tells me, no, you're not. So when I look at those pictures, I don't see, I don't see myself in there. So we need to get veterans that are closer to that age, right? And then discuss geriatric in a different light with them, right? Advanced care, not advanced age, advanced veteran, and stay away from geriatric. That would be my suggestion.
Yeah, very good. Thank you very much. I yield back, Madam Chair.
Thank you. Mr. Butler, thank you very much for your testimony. In my younger years as a nurse in the Army, I was on the neurosurgery floor on Walter Reed on Ward 10 and turned a number of striker frames and worked with spinal cord injured veterans quite a bit, as did my husband, who is a nurse. So in your testimony, you mentioned the importance of coordinated care in this population, the SCID community, and what strengths in the hub-and-spoke model of care could work in other areas of VA care. And should the VA focus more on complex populations like your membership, rather than investing in numerous coordinators who try to manage a more basic general population?
I think, thanks, Chairman Miller Meeks, for that question. VA has an excellent model, VA's spinal cord injury system of care. So one thing that they could do is examine that model, and why is that model so superior to the coordination of care throughout the SCID program in comparison to care outside of that system. They may find that there's some uniqueness in the way the SCID care is delivered throughout that system that they can use throughout the entire VA healthcare system to gain some leverage in the coordination of care outside the SCID system of care.
As a template, then?
Yes.
Ms. Sawyer, in your testimony, you and Mr. Brady both mentioned the Federal Recovery Coordinator Program. And as you heard me in the last panel, and I thank the previous panel for still being here, you heard me say the old adage, if it ain't broke, don't fix it. So it sounds like we developed an FRC program in order to fix the deficits after 9/11 in coordination of care, and it seemed to be working. So what were the strengths in that program that should be continued, and what were the barriers that proved to limit continued implementation today?
Sure, I'll go. Chairwoman, a great question. When it was in full implementation, the FRC had great latitude in which to really execute, right, the plan for the warrior, to execute where it was going to go, not just in the DOD, but the VA, the benefits, the Social Security Administration. This incredible amount of latitude in which to work really centered on the injured veteran. I think the problem with that is we got away from that, and now we're at a level where there's not the direct interaction. There is not the direct care with developing the care plan with the veteran. There's a level of ownership, I think, when you're an advocate, when you're somebody in a federal recovery coordinator. There's some ownership in the people you deal with and how you treat them and where you see them going. So I think that we've gotten to a point where there's much fewer, they're farther in between, and this may have been a consequence of, obviously a drop in the amount of wounded veterans coming back. So that's what I would say.
So it sounds like what you're saying is that we're going from a program that worked but had less wounded veterans coming back from war to now a bureaucracy-centered coordinator rather than a veteran-centered coordinator or case manager. Ms. Sawyer, you talk about seeing veterans with care managers who typically manage one clinic or one specific disease program, which is what I mentioned earlier. That seems to align with what the committee sees as multiple layers of coordinators, advocates, and champions that have little overlap in function and limited ability to extend past their respective silos. And I know I'm running out of time, but what does the VA need to do to truly provide care coordination with veterans with complex needs? And then in writing, if the three of you could submit to the committee, are there any organizations outside of the VA, any health systems that you think do case management and care coordination especially well? If you could refer that to us.
So I will be glad to do that. There are several that are out there. One of the things I wanted to respond to with that and with your question, we do see these very siloed case managers. And one of the reasons I said especially trained cadre is not because I think VA needs to add more employees. I do not. I think we need to realign the employees we have. I do agree with the VA when they stated that care managers are very single-focused and siloed, but what you need is a person who is trained to be able to look at all of those clinical needs together. And it is simply just so when I said a specially trained cadre, I simply mean that you take some of those people who are individually siloed and train them to be an across-the-board case manager to look at all of these individual care plans that each specialist puts in place, see where they overlap, see where they are contraindicated, and be able to weave those things out, give your family a single point of contact, and be accountable to see that each one of these plans and needs that the warrior has can do that, they can be accountable for that and for helping manage that. But I also think it's important that that person be responsible for portraying to the VA what the veteran wants. And I feel like in this system, a lot of times, as a caregiver with a veteran and with the cases that I work also, is that I have the VA telling me a lot of the times what we are going to do, and it doesn't fit in with what we want to do, and that's not something in the civilian medical model that we deal with.
Thank you. I know all of you would want to answer that question. I've already gone over my time. Ranking Member Brownlee, would you like to make any closing remarks?
Thank you, Madam Chair. I will just say that I think this is a really, really important discussion, and we haven't even touched upon some other care coordinators in the VA. For example, for women veterans, all of their, if they become pregnant, all of their health care needs are outside of the VA. There's a coordinator for that to make sure. But they don't even have the chance, really, except for their primary caregiver, not even have a chance within the VA that somebody might pick them up and advocate for them in terms of services they need. They're lost on the outside. And I've spent some time going to other medical centers across the country. We made a lot of trips, I think 2 years ago, but spent a lot of time in Texas and Oklahoma. And I mean, every medical center that we went to, the maternity coordinator was way overworked, way overworked, and no way that she or he could possibly manage the caseload that they had. So I think this is an important conversation to have. I think we have to even dig deeper, and I think we need to watch carefully what the VA is doing in terms of a solution, and say our piece. With that, I will yield back.
Thank you, Ranking Member Brownlee. I'd like to thank everyone for their participation in today's hearing and for the productive conversation. It's one of my priorities, and I know the same goes for my colleagues on both sides of the aisle, to take care of all veterans and to ensure that care is being properly coordinated to meet both the patient's needs, the family's needs, and improve health outcomes. No veteran should be left in the dark about their ongoing medical care or the coordination of that care. I look forward to working on these issues and many more with the department, the stakeholders, and my colleagues on this subcommittee. The complete written statements of today's witnesses will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. And again, I would ask our panelists to provide for us any medical care, healthcare systems that you think does an exemplary job of case management care coordination. Hearing no objections, so ordered. I thank the members and the witnesses for their attendance and participation today. This hearing is now adjourned.